Alright, good morning. I'm going to be presenting a patient that I saw on rounds this week. So, Mrs. M is a 44-year-old Hispanic female who was brought into the emergency department by her mother with complaints of generalized weakness and altered mental status. The onset was 6 months ago, but getting progressively worse 2 weeks ago. The severity of the symptoms got worse, so the patient was unable to receive any nutrition or hydration by mouth and became incontinent, both urinary and bowel, so the mother decided to seek medical attention. There weren't any relieving factors, however, the patient has an extensive medical history of multiple myeloma and was receiving chemo and radiation, which could have played an aggravating factor in the patient's symptoms. The patient is intubated and sedated at this time. The history is obtained from her mother, who is the patient's power of attorney and caregiver. The past medical history consists of multiple myeloma. She was diagnosed in November of 2017 and seizures that she's had since she was a kid. Since she was diagnosed, she's had multiple admissions to the hospital. Latest ones were for pneumonia in December of 2017 and colitis and UTI in January of 2018. Only surgical history was a cholecystectomy in 2010. The medications that the patient takes at home are Tylenol 3 for pain, Celexa, Sofran, and that's about it. She's got no known drug allergies, no food allergies, and no latex allergies. Social history: Ms. M was born in El Paso. She's disabled due to her multiple myeloma. She is married but legally separated from her husband at this time. She's currently not sexually active. She lives with her mother and her 2 sons. She does not smoke, drink, or do any other drugs. She is not functionally independent. She needs help with every ADL, and her mother is her full-time caregiver. As far as immunizations, all of her shots are up to date, and she did receive a vaccine, her flu shot, last year. Family past medical history: her mother is alive and her only history at this time is diabetes. The father died at 68 and he had a history of heart disease. She's got 2 sons. They're alive and have no medical histories. The ROS was unable to be obtained due to the patient's, she's intubated and she's sedated and she's not able to answer questions at this time. As far as the physical exam, generally Ms. M is a 44-year-old female. She's lying on the bed. She appears pale and disheveled and uncomfortable. Vital signs are blood pressure of 89/56, heart rate of 112, respirations of 24, temperature of 98, and she's sitting 96% on the vent. HE and T: the head is normocephalic, symmetrical, the hair is well distributed, the eyes are bilaterally symmetrical, pupils are equal, round, and reactive to light and accommodation. Unable to test visual fields as the patient is unable to open eyes or track at this time. The sclera is white but edematous. Ears are symmetrical, no erythema noted. The nose is patent with no drainage noted. The oral mucosa is dry and pale but intact. There's an ET tube in place. Respiratory wise, the chest expands symmetrically. The patient is being ventilated. She's got a size 7 ET tube, 24 at the lip. Breath sounds are clear on the upper lobes, slightly diminished on the lower lobes. No wheezing, crackles, or stridor is noted. Cardiac wise, the heart sounds were auscultated with no abnormal or extra sounds heard, no murmurs, gallops, or rubs. Regular rate and rhythm. Cap refill is less than 3 seconds to all extremities. Pulses are present to all extremities as well. No significant peripheral edema noted. GI: on inspection, the abdomen is obese. There are no visible scars or masses. Upon auscultation, the bowel sounds are normal, active in all quadrants. On palpation, there's no tenderness. The OG tube is clamped at this time. The patient is too unstable to start feedings. And the last bowel movement was last night, reported by the nurses. She's incontinent and it's brown and soft. GUIs, the patient has a Foley catheter. There's no discharge from the vagina. The urinal output, however, has been inadequate, less than 30 cc's an hour. Neuro-wise, the patient is sedated, does not follow commands, GCS of 6. DTRs are 2+ and equal bilaterally. We're unable to test the cranial nerves at this time, as she's sedated and she's unable to answer questions. The skin is warm. There's no masses, lumps, or scars. There's multiple purpuric lesions on the forehead that are flat and non-tender. Otherwise, the skin is intact. No pressure ulcers, cuts, scrapes, or rashes noted. The lesions that she has right here on her forehead are from her multiple myeloma. Psych-wise, we're unable to assess due to the patient's inability to answer questions. Her lab work is as follows. Sodium of 141, potassium of 5, chloride of 111, CO2 of 9, BUN of 21, creatinine of 2.2, glucose of 96, white count of 16, hemoglobin 7.4, hematocrit of 22.3, platelets of 143, lactate of 20, and ammonia of 128. The UH was showed that the urine was dark and amber with a specific gravity of 1.021, positive for glucose, positive for trace ketones, positive for leukocytes, +2 of protein, and positive for IBCs and WBCs. She's had multiple radiology exams done, and so far the chest x-rays impression of the radiologist showed that the patient's lines and tubes are in good position. Irregularity of the right lateral third rib related to an old fracture with rib lesion not excluded. The CT of the brain showed multiple lesions correlating with the history of myeloma. CT of the abdomen pretty much showed the same thing, some hypervascular lesions in the liver, and then the chest wall mass from the rib, and then multiple lesions in the spine and pelvis consistent with the mets of the multiple myeloma. So as far as my assessment and my plan, the first diagnosis is multiple myeloma. The patient has metastasis everywhere: the chest, liver, spine, pelvis, and brain. So according to current guidelines, the first line of treatment for patients who are good clinical condition, the induction is to follow by high dose therapy of stem cell transplantation. And that's the standard treatment right now, but the patient is in an advanced disease and is not currently stable for treatment. We consulted the patient's oncologist for input and for medical management, and he said that right now, since the patient is unstable, he's not going to be able to proceed with treatment of chemo at this time. Next diagnosis is a UTI. So the patient's already on vancomycin and Sosin, so we're going to follow the cultures and de-escalate the antibiotics as needed. The next diagnosis is septic shock. The patient received 2 liters of NS, maintenance fluids of 150 an hour. She's on double broad spectrum antibiotic on Sosin and Vanco, and she's on Levofed because Levofed is a vasopressor of choice for septic patients according to current guidelines. The last diagnosis is acute renal failure. The patient has acidosis with renal failure and oliguria, so we're going to give her 3 amps of bicarb. We consulted a nephrologist who placed a dialysis catheter last night to attempt dialysis, but she was too unstable on multiple pressors for she was too hemodynamically unstable for dialysis, so we'll continue to optimize the blood pressure for possible attempt at dialyzing today. And that's it.